I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm delighted to have with me Dr. Larry Allen, Professor of Medicine from the University of Colorado School of Medicine, who is Principal Investigator of the EPIC Heart Failure Trial. Welcome, Dr. Allen.
Thank you so much for having me.
The EPIC Heart Failure Trial tested the effectiveness of patient engagement using a digital health tool on the optimization of heart failure medications in the ambulatory setting. Tell us why you undertook this study.
So I'm a heart failure doctor, and the patients that I see typically have heart failure with reduced ejection fraction or a weak heart. And the good news for patients like that is we now have many therapies for these patients that work together and additively can really improve cardiac function, keeping people out of the hospital and helping them live longer. But unfortunately, what we've seen is a lot of therapeutic inertia in that if you look, the majority of patients are not getting these evidence-based helpful therapies either prescribed at all, or even when they are prescribed, they're prescribed at doses that are too low. So for example, in this study that we just published, EPIC Heart Failure, we started out with about 300 patients. And when we looked and said, how many of those patients are getting what we would say is an optimal or really good collection of medicines prescribed for them, the answer was 0. Our thought was that telling providers or doctors to do a better job has not worked very well. And telling patients to learn about their drugs and all the details about their drugs has not worked very well. But I think with my work over the years in patient engagement, we do think that patients who are kind of emotionally motivated to do something about their care, actually going in and talking to their doctors and having a dynamic discussion or shared decision-making discussion has been more productive. So as you mentioned in EPIC Heart Failure, what we did is we went to our health system. We found 300 patients with heart failure who were going to go and see their cardiology provider, either their doctor or nurse practitioner, in the clinic. And we randomized them. So half of those patients just came and had their usual clinic visit, and the other half, actually right before they went into their visit, they either got a text or an email or both that had a URL link to a 3-minute video that really told the patient that they should be motivated to try and find an opportunity to make one positive change in their medicine regimen. And then it gave them a 1-page checklist to bring into the visit, and then look at that checklist and talk to the doctor about, like, where's my best opportunity to improve my regimen? And so we did this, and we just got the results back. And I think they're pretty exciting. It showed that in 30% of the visits that were usual care, some improvement in care was made. But 70% of patients the doctor said, hey, you look like you're doing great. Thanks for coming in. Glad your family's good. We'll see you later. Come back in 6 or 12 months. And in the group that was randomized to the intervention, a 3-minute video and giving them a 1-page checklist, 50% of patients had an improvement in their medication regimen. So, 1 out of 5 people who came in actually did something I would say is more positive in their prescribing, and hopefully over the long term, that would translate to a more proactive evidence-based regimen that would lead to better health outcomes. So that's really the summary of why we did it. And we were pretty excited to see that a small, simple intervention seemed to make some difference.
Right. Given the purpose of this work to engage patients, did patients weigh in on any aspect of the study design or selection of outcomes?
We did. So we actually have been working on a variety of tools to help improve patient involvement, patient engagement with care, mostly in the cardiovascular setting, because that's where I work and cardiovascular disease is so common. So our Colorado program for patient-centered decisions has developed a variety of tools. And when we develop those tools and write grants to get money, we have a panel of patients who have really helped us and are really collaborators or co-investigators in the process. So we have kind of a go-to group of people who have been really helpful. The second thing is that most of the tools that we've developed, including this Epic Heart Failure 3-minute video and PDF, when we're developing, we do it an iterative development process where we have an idea, we sketch it out, we make a rough draft, and then what we do is we say, go and find 5 patients and maybe 5 doctors or nurses, and then we say, hey, what do you think about this? And then we rapidly do prototype development, and then we make some changes, we talk amongst our group, and then we go out and we find some more patients to provide input on that.
Were clinicians blinded to allocation?
They weren't. This was actually randomized at the patient level. So we enrolled patients and then we randomized them. And so we actually touched a little over 60 providers or doctors and nurse practitioner PAs in our system. And some of those providers actually saw patients who had been randomized to the intervention, and some saw patients who hadn't. So I think there may be some diffusion across, so maybe the benefit would have been even greater because some of our doctors are getting used to seeing their patients come in and say, hey, I've got this 1-page PDF, and then they see the next patient who's not enrolled to it, and they could say, oh, I actually need to do a better job of increasing drugs. And so actually we've done some prior work that showed that only about 20% of visits had an increase, and here we saw 30%. So I do think that, it is an interesting dynamic because we're mostly focused on the patient and activating, motivating the patient. But it's really a partnership between the healthcare provider and the patient. And clearly some of this carries over and involves the provider as well.
Right. I think the biggest source of bias, perhaps, in this study would have been the unblinded nature of the study.
That's right. Specifically that providers would feel like they were being graded. So that if we, in the study, you would see a big difference. And then when we said, oh, now we're just going to do it for everybody. And then providers would be like, oh, well, nobody's looking at me anymore. I'm not going to follow it. I agree with you. I think that the lack of blinding is really hard to handle.
Mm-hmm. Did you test for patient adherence to the intervention? I know that the intervention was delivered right before the encounter, but was there a way of checking to ensure that the patient had successfully read through the materials and brought the patient up in conversation with their cardiologist or nurse practitioner?
Yeah, we did. So all patients in the intervention group, about 3 days on average after that visit, were given a questionnaire to say, hey, did you get the intervention and what was your experience with it? And actually not all patients even returned that. We had pretty good response rate. And among responders, about 2/3 of them said that they got it and opened the video and watched the video. And actually, I was a little surprised. Half of them said they printed out the PDF and brought that to the visit, or either printed it, I think was most common, or some people actually said they just brought it in on their iPad or tablet, or even their phone, which it could be seen on. So the fact that about half of people brought that into the room, I think was really positive because, as you know, or at least as a clinician myself, it is really nice when people come in and ask a question to have something to anchor the conversation around. And so having that 1-page thing to look at the different drugs and then have a conversation about which opportunity seems most useful or valuable to that patient is actually helpful.
Is this app or tool available for dissemination to other centers at this point?
It is. We've really funded our work over the last decade through a variety of mechanisms, but they're all mechanisms I think are public. So we have National Institutes of Health funding. A lot of work that we've done is funded by PCORI, or the Patient-Centered Outcomes Research Institute. Both of those are federal. And then this work for Epic Heart Failure was funded by a large grant from the American Heart Association. And their income comes from lots of places, but a lot of it is actually patients and families donating money who've been affected by heart failure, heart disease. And so they gave us a grant, a 4-year grant to run this study. And so because I think we've had public funding for what we've been doing, our policy has always been to make the results of our research publicly available. So we have a website, patientdecisionaid.org, and at www.patientdecisionaid.org, there are all of the tools that we've made, including the Epic Heart Failure video and checklist. And we actually recently just updated our checklist to reflect the most recent advances in heart failure medical therapies. So that's available for use. Anybody can use it. Our only ask is that if people modify it, that they get our permission, but we let people use it and health systems use it.
Your primary outcomes were process outcomes, but you did
Yes.
measure clinical endpoints as safety endpoints. What do you make of the slight signal towards risk of emergency services or hospitalizations in the intervention group?
As you mentioned, they went in the wrong direction, which is that there was about a 3 to 4% increase in the number of patients in the intervention group that within 30 days either presented to the emergency department or got hospitalized. So it was about 6% to about 10% between control and intervention. I think that is important to look at because increasing heart failure medicines, even though over the long term they seem to improve heart function and reduce events, in the short term, if they are inappropriately prescribed or inappropriately monitored, they can actually cause problems like excess low blood pressure or kidney failure. So we did want to look for that and see if there were an increase, that if patients came in demanding, per se, they saw the video and they're demanding that they get their drugs increased, would that cause problems? So I think it's provocative. On the flip side, I would say, as most statisticians would say, is that, you know, if you're not really powered to look at an outcome, it is a little dangerous to overread a small trend in an outcome as being significant. So I would argue that in the 30 days after increasing these therapies, we did not expect to see any improvement in these patients because most of the drug therapies that are being prescribed have long-term benefits and not short-term benefits. So one is we weren't expecting to see ED visits and hospitalizations go down. And secondly, I think that difference that we saw, there's a very good chance that it is the play of chance. So I think making sure that a couple of things. One is that that education to providers around making sure that they are monitoring and having patients check their blood pressure and know that the medicines can cause problems is important. We knew that before doing the study. And if people were to roll this out more broadly, I do think that a safety signal does suggest that people shouldn't do that willy-nilly, that it does need to be part of a systematic approach that includes regular monitoring of these drugs.
Yeah, I agree with you. It merits looking into because you saw this hint both for your emergent visits and your unplanned readmissions. And yes, it was underpowered to show statistically significant differences. And perhaps that's why you didn't see it. And we certainly see this through many health service interventions. It may be that the patients are more engaged, know what symptoms to watch out for, and
Yes.
when emergent care. It may also mean that our ambulatory services are insufficient to provide that semi-urgent care that patients need after hours. And so they're left with no recourse other than hospital services. So something to look into.
I like your comment about the reasons why people show up to the emergency department, get hospitalized, are incredibly complicated. Heart failure is, among older adults, the most common cause of hospitalization. It's really important. And yet, you know, the last decade, there's been a lot of attention on heart failure hospitalizations. And I think even though we've had lots of studies and lots of data and lots of observational information, I don't think we know what even drives all of these. And some of them are not necessarily bad, to be honest.
My last question has to do with access to care. I think some people who may not be within the circle of digital health services raise the issue of access and affordability and the risk of creating a two-tier system when we focus on digital health interventions, that in some ways we deprive patients of the lower socioeconomic groups access to the same level of services. On the other hand, virtually everyone in this world has some sort of device that they have access to, particularly smartphones. Did you find that there were any barriers to care, either due to limited bandwidth access or limited devices or cognitive or financial ability to participation in your trial?
Yeah, so I think that's a great comment. This issue of not only equity in healthcare, but the concept of the digital divide potentially exacerbating those inequities is really important. And you mentioned some of it around social determinants of health, including kind of financial access to technology. But the other thing that really comes up in heart failure is that that heart failure is a disease of older people, and the digital divide then becomes significant, not necessarily so much based on money, but based on people's familiarity with technology. So this was a concern. I think we actually did see some problems with this. The first is that the average age in our study was 65. And if you look at the average age of a heart failure patient, it's about a decade older. Although most heart failure trials actually have an average age of like around 61. So I think that's part of the problem. The other is that one of our regional sites in Colorado Springs actually services the part of town that tends to have more indigent care. And that site had more refusals because especially their older indigent patients said they did not have a functional email or smartphone where they could receive the URL link and then upload the video. So it's real. On the flip side, I would argue that the approach that we took actually did involve a lot of user-centered design and took that into account. So this is a very simple intervention. And so one of the things that we could have done was to have a complicated medication sheet where people had to upload their information and put all their pill doses into some kind of online data capture. And our decision was that that would probably exacerbate the disparities that you're talking about. So we decided to go with a very simple design that I think the majority of people could actually simply access. And then that discussion about the details of the patient's regimen actually then are left to the provider and the patient in the clinic environment. So I think design issues can help limit those things that you just brought up.
Wonderful. Well, thank you so much for joining us. It was such a privilege for me to meet you and to talk to you about your work. It's fascinating. I think that the design was well thought out. I love that you engaged patients in the work. And I think it was very strategic to choose process outcomes rather than clinical outcomes as the primary endpoint. I hope we get to meet in person, but I'll settle for a virtual interview on this occasion. Thank you so much for being with us today, Dr. Allen.
Thank you so much for having me. It's been a pleasure.